Suprascapular neuropathy, or SSN, is a relatively rare but significant cause of shoulder pain and weakness. Affecting just a small percentage of those with shoulder complaints, SSN can lead to functional limitations, particularly in abduction and external rotation of the arm. This is due to impaired innervation of the supraspinatus and infraspinatus muscles. While the condition is uncommon, it is especially relevant for athletes involved in overhead sports such as volleyball, and for individuals who have experienced trauma or repetitive shoulder movements. Diagnosing SSN can be challenging, as its symptoms often overlap with other shoulder conditions like rotator cuff injuries or tendinopathies. Electrodiagnostic testing, particularly electromyography (EMG), is considered the gold standard for confirming SSN. Imaging studies, such as MRI and ultrasound, can also help identify structural causes or muscle atrophy. In this video, we'll explore findings from a comprehensive review of 87 SSN cases, shedding light on causes, diagnosis, and recovery. In the reviewed study, trauma emerged as the most common cause of suprascapular neuropathy, accounting for nearly a third of cases. This includes injuries from motor vehicle accidents and falls. Other notable causes were neuralgic amyotrophy, also known as Parsonage-Turner syndrome, and repetitive overhead activities such as weightlifting or sports. Interestingly, SSN was often found in isolation, but a significant number of patients also had associated axillary neuropathy, which can further limit shoulder movement. Most patients presented with shoulder pain and muscle weakness, and nearly half showed muscle atrophy on imaging. The study also highlighted that patients with isolated SSN were more likely to have sports-related or idiopathic causes, while those with combined axillary neuropathy were more often affected by trauma. These findings underscore the importance of a thorough clinical evaluation and tailored diagnostic approach for each patient. Diagnosing suprascapular neuropathy relies heavily on electrodiagnostic studies, with EMG and nerve conduction tests providing crucial information about nerve function and muscle involvement. In this study, nearly half of the patients had abnormal MRI findings, and a similar proportion had abnormal ultrasound results, supporting the use of imaging in the diagnostic process. Treatment typically involves pain management and physical therapy, with surgery reserved for select cases such as those with compressive lesions. Recovery rates were encouraging, with about 78% of patients showing improvement, often within 18 months. However, the study found that certain electrodiagnostic findings like CMAP amplitude were not strongly predictive of recovery, suggesting that multiple factors influence outcome. Early referral to a nerve specialist is essential for severe cases, as timely intervention can make a significant difference. Ultimately, this research highlights the need for comprehensive evaluation and individualized care for patients with SSN. Findings from this review of 87 cases provide valuable guidance for clinicians managing patients with shoulder pain and suspected suprascapular neuropathy. Recognizing the association between SSN and axillary neuropathy is particularly important, as it may prompt additional diagnostic testing and influence treatment decisions. The study also highlights the limitations of relying solely on certain electrodiagnostic markers for prognosis, emphasizing the need for a holistic approach. However, it's important to note the study's retrospective design and some gaps in follow-up data which may affect the generalizability of the results. Despite these limitations, the research underscores the importance of early diagnosis, comprehensive evaluation, and individualized management strategies to optimize outcomes for patients with SSN. As our understanding of this condition grows, ongoing research and clinical vigilance will continue to improve care for those affected.